Ladies and gentlemen, welcome to this lunchtime symposium. My name is Marlies Ostermann. I work in London in the UK, and I'm deeply honored to co-chair this exciting session with the boss. And here we have Professor Claudio Ronco, the master of everything and the master behind this great meeting.
Well, don't flatter me too much. So, I think I want to explain that the program of the sponsored symposia are not intended to be kind of presentation of a product, but rather a real integration of the scientific program, so that companies help us to further expand and develop the message that we have in other different aspects. So with this, we have to consider that we have interesting speakers, of course, which are basically Tiago Duarte from Portugal and Nattachai Srisawat from Thailand. And the theme is Hemoadsorption in critical care, which is something which we may consider a hot topic. So Marlies, do you want to introduce the speakers?
Of course, yeah. It gives me great honor to introduce Professor Duarte, who will address hemoadsorption as an adjunctive therapy in septic shock beyond vasopressors. Professor Duarte, the floor is yours.
Thank you. Let's start this interesting discussion talking about hemoadsorption beyond vasopressors. These are my conflicts of interest. We all know in critical care that sepsis remains a really important question. It's important because the mortality in hospital, in ICU, outside the ICU, the mortality remains high, so it is an important question. And we know from the data that mortality has two biphasic distribution, early one and a late one. And this mortality impacts our society. We estimate by numbers from 2017 11 million deaths per year, which is more or less 1 in 5 patients die from sepsis. Of course, the mortality has been decreasing slightly, but still, when we talk about mortality in sepsis, we speak about 40, 50, 60%. Some cases tells a bit higher, and that's a quite important question. If you look at the definition, we see a life-threatening condition caused by an excessive host response to infection that can lead to severe multi-organ dysfunction associated with high mortality. This concept of excessive dysregulative host response is an important one, and it's not new. It has 100 years, this discussion. Inflammation, of course, is not always the bad guy. Inflammation is important for us to fight infections. It's important that the tight junctions open, that the cells migrate, and they try to fight the infection in that place. But some individuals, we know that inflammation is worse. It's dysregulated and can be harmful. When you look at some articles, the inflammatory response has two components, the pro-inflammatory component and anti-inflammatory components, both occurring at the same time. But in an early phase, we have a more pro-inflammatory component because of the endotoxins, the inflammatory mediators, cytokines, that can lead to microcirculatory dysfunction and to acute organ dysfunction. We know from the guidelines what we need to do. And we try to do it. They are the main responsibles for the reduction in the mortality in sepsis. Antibiotics as early as possible, source control, try to do it earlier too, organ support, hemodynamic management, fluids, vasopressors, in some patients inotropes, management of acute respiratory failure, high flow nasal cannula, non-invasive mechanical ventilation, invasive mechanical ventilation, management of acute kidney injury. We may need renal replacement therapy, and modulation of the host response. But even though we do all of these things as early as possible, in a golden window for rescue, we see daily that some patients die despite we do everything correct. They became worse, and we increase the dose of pressors. I don't know in your countries, but in Portugal, we don't have a maximum dose of noradrenaline. We increase, join another pressors, but we increase. And we know that high dose of pressors are also toxic. And then patients develop irreversible organ damage. So we need to think a little bit far from this to try to improve patients' outcome. And we can think about hemoadsorption in sepsis. And the principle when we think about hemoadsorption is regarding the modulation of inflammatory mediators. Try to attenuate the sepsis-related systemic inflammatory response. And when we think about it, we think in different mechanisms, like try to remove endotoxins, the main trigger from inflammatory response, try to decrease the peaks of cytokines, so like the peak concentration hypothesis, try to partially remove cytokines from circulating blood, to reduce the peak concentrations during the early phases of sepsis, that it may help us regulating the inflammatory cascade. We can also think about the modulation of the gradient of inflammatory cytokines in infected tissue and the systemic, the systemic circulation. These are all mechanisms of action we can think when we talk about hemoadsorption. These are some of the techniques, the sorbents we have available. We have non-selective removal with cytosorb, with the Jaffron cartridge 330, 380 to remove cytokines. We have a more selective removal with polymyxin B. We have the ShareUp to adsorb directly bacteria. We have also the CRRT filters, like the Oxyrus for endoabsorption and cytokine absorption. We have the high-cut membranes like HEMIC2, membranes with increased pore diameter to achieve higher size middle molecules, but we have the problem of removing albumin too. And we have other techniques that we won't talk a little more in this presentation. But when we look at the literature, what we may find. This is an important clinical trial. The EUPHRATE is a randomized clinical trial, multi-center, done in North America, published in 2018. And it was a study that compared outcomes in patients treated with polymyxin B hemoperfusion and versus patients treated with conventional medical therapy. And the aim was to remove endotoxins from the blood. What we see, they selected patients with septic shock. They started with low doses of norepinephrine. They add the measurement of endotoxin activity assay, a 0.6 higher value they included these patients. And they also did a subgroup of patients with multiple organ dysfunction score. They did 2 treatments, one each day, separated 24 hours of treatment with polymyxin B. But what they found was not a change in mortality. It was a little bit disappointing, but because they selected those theoretically patients who would mostly benefit from this complementary treatment. But then when we look at the post-hoc analysis, it's quite important, and they reassess the inclusion criteria patients. They change the range from endotoxin activity assay from 0.6 until 0.89, and when they change the patients, when they change patient selection, they find a significant reduction in mortality in the group of polymyxin B, changes in mean arterial pressure, in ventilator 3 days, and survival at 90 days. So, if we find the right patients for the technique, maybe we can find the differences and the benefits. if we continue to look in the literature, this paper published this year, randomized and control Bayesian network with meta-analysis of randomized and controlled trials that included blood purification techniques in severe septic shock patients. What we see, they included 31 randomized controlled trials, a lot of patients, an Apache 2 higher than 25 or a SOFA higher than 10, more or less a mortality higher than 50%. And what they found was 15 different treatments. 15 different treatments that are resumed here in these lines. Of course, it is difficult, even though you use a Bayesian network, to compare different treatments between them. Nevertheless, polymyxin B and Jafron AA330, they found a slight reduction in mortality. Another paper from 2025, they included septic shock in a surgical ICU. They included patients with Apache higher than 15, a SOFA higher than 2, with the need for renal replacement therapy. They use CVHDF 35 milliliters per kilo per hour. They did sections with HA 380 for 2 hours and a half and 5 hours. The main source of infection were intra-abdominal infection, respiratory infection, and they found slightly decrease in some biomarkers, a reduction in organ dysfunction in Apache, not in SOFA, but no difference in mortality. And I could tell you a lot of other studies using different cartridges. And almost the majority of them has the same problems. When they do systematic reviews and meta-analysis, it's difficult to find benefits in mortality. They found benefits in reducing the dose of pressors, improvement in organ dysfunction, a reduction in some biomarkers. But if we look at clinical observational trials, maybe you find some benefits in mortality. But when we do with meta-analysis and randomized controlled trials, it's difficult to find this difference. So in my hospital in Lisbon, we use this Jafron cartridge for almost 2 years. I suppose as your hospitals, not everyone uses these kinds of therapies, even inside of our ICU. So we decided to look to what we are doing. We use the cartridge, some of us do, others don't. Let's look at what we have been doing with this. So we present here 24 patients, of course, small number, all the patients with septic shock and the use of this cartridge. As our ICU is connected to liver failure patients, liver failure program transplant on transplantation, we have almost 50% of chronic liver disease in this study, and 20% of hematologic malignancies. So patients usually that anyone likes to treat, and because our patients that die has a high risk of dying. When we compare the survivors and non-survivors, it was a 50-50, so 50% died. But when we look at them, if you notice, the non-survivors were older than the survivors. The Apache, SAPS 2 and SAPS 3 estimated the mortality almost 80%, quite high. The SOFA was slightly inferior in the survivors. The main source of infection was peritonitis, intra-abdominal sepsis, and gram-negative sepsis. But then we asked, what kind of treatment we have done with these patients? The first cartridge duration was, when we started the cartridge, how many hours the same cartridge stayed in the patients. In the survivors, 7 hours, the median. With non-survivors, a little bit higher. And did we change the cartridge or not? The median number of cartridges was higher than survivors than in non-survivors. So the treatment we have done was different. Here is the difference. Then we looked at the time between when the patient started noradrenaline and the starting of the cartridge. If you see, in the survivors one, we started a little bit earlier the cartridge. The patients were on noradrenaline and vasopressin, the survivors a little bit earlier. And then you look at the antibiotics. Some papers don't tell us how the antibiotics work in their reports. So we looked if the antibiotics, one of the golden measure that we cannot forget when we are managing a patient with septic shock, if we did it okay or not. So in the non-survivors group, we found that we fail antibiotics in the 24 hours. Most of these patients came from other hospitals. They had multi-resistant microorganisms, but we didn't suspect. They didn't have any risk factors for that. Okay, but we failed. And the source control was even inferior in the non-survivor groups. If you look at the noradrenaline, when it started the technique, was a high-dose noradrenaline. Of course, with the technique, we found a decrease in the noradrenaline, which also happened in the non-survivor group. We had a decrease in the procalcitonin and a decrease in IL-6, as you can see here, even though some patients, some non-survivors, of course, they died. But when we look at the Surviving Sepsis campaign recommendations, I'm almost finishing, of course, we may not be disappointed with the conclusions because we are uncertain of the impact of blood purifications on mortality. Did you hear the studies? We agree with it. We are uncertain, but there is a sign for reduction in short-term mortality. We see a sign, but we need to do something to make that sign reproducible in other studies. The certainty of evidence is low, due to various factors, and we need to identify clinical phenotypes which may benefit from blood purification techniques. And to end, where are we going? We need to define what we want to remove. Cytokines, endotoxins. We need to improve patient selection. And the Tigris trial, it's a light for this. We need to improve patient selection. We cannot analyze septic patients and put in the same analysis gram-positive, gram-negative, intra-abdominal sepsis, respiratory sepsis. Patient that started the cartridge in the first 24 hours, they started the cartridge after the 24 hours. We need to include separate the data, try to find the difference in the patients and find the clinical phenotypes. Of course, the timing and dose of adsorption is important. We can compare different treatments. We need biomarkers. That was already mentioned. We need biomarkers too in this big picture. If we join clinical data and biomarkers, to have a big picture and find the correct patients to start this treatment. And in my opinion, I think we need to think of non-mortality endpoints. We are always looking for mortality in this kind of situation. Mortality in sepsis is multifactorial. It depends on a lot of things. So we need to see other things besides small mortality. The prevention or the management of organ dysfunction. The time under vasopressor support, the time under mechanical ventilation, the length of ICU stay, the prevention of chronic kidney disease, the quality of life. Maybe you should think about this. Antibiotics are a concern. We should measure, do TDM. And if we are expecting that a single therapy to drastically reduce mortality from sepsis, in my opinion, is not realistic. I think we have arrived to a time that the team one size fits all in sepsis has finished. That's my point of view. So thank you for your attention.
Thank you very much. We will have discussion if there is any time left at the end. Nattachai, you are going to present the second talk of this symposium.
Thank you very much, Professor Ronco. And thank you for the invitation for me to share our idea about how to start the hemoperfusion in sepsis patients. So this is my conflict of interest, and this is the topic that I would like to mention. The first thing is I just would like to emphasize that sepsis is quite a global burden. More than nearly up to 50 million people suffering from sepsis each year, and this comprises about 11 million dying from sepsis related. And with the present time, the mortality rate when you develop the septic shock, it can be up to like a 40%. And as mentioned by Professor Fuente, that sepsis, septic shock is a sepsis cascade starting from infection to the phase of immune activation, and after immune activation that can lead into organ injury via the process of vasodilatation and plasma leakage. And one of the major mechanisms that driven the organ dysfunction in sepsis is not only the bacteria virus by itself, by themselves, but they also have the kind of the mediator load that driven the organ injury, and this accumulate over hours and hours. When we look into the peak cytokine hypothesis, that this is kind of the emphasize the importance of why timing is so important in sepsis. As you can see that at the peak of the cytokine or mediator uprising during the early phase of the sepsis, and until they reaching at the toxic threshold, this might be the time point that the sepsis process is not irreversible. So the way that we're thinking about this one in terms of the timing, that why emphasize the importance of the early phase before the patient up into the late process. And in that late process, the patients may get into the stage that we call immunoparalysis. And the treatment that we mentioned, like steroid or hemoperfusion, may not work. Why we need the hemoperfusion in this stage? As you can see that even we have the optimal antibiotic treatment, source control, it can be up to 30 or 40% of the patients still dying from sepsis. And one of the major driven in this process, as mentioned, is this kind of the mediator, including DAMPs, PAM, and endotoxin cytokine. These are driven the cause of death in sepsis. The benefit of this kind of treatment hinge on when and whom that we should start it. And also when we look in the peak hypothesis concentration again, you can see that if we can mitigate and cut down the peak concentration of the mediators before they're reaching into the toxic threshold, this is kind of the key concept, that if we can identify this point and provide the treatment to the right timing, we can we can reverse the process of shock, and the patient also may require less of a vasopressor and may lead into less organ damage and morbidity and mortality outcome. Not only the peak concentration hypothesis, but this kind of the hemoperfusion technique that mitigate the cytokine and mediator also quite fit to other sepsis theories like a threshold immunomodulation and by Professor Honore, and mediator theory by Professor Alexander and Di Caro. And when we look into the adjunctive device that we have in the market, as you can see that there is a variation of the cartridge that can absorb based on their different structure. The HA330 based on to modulate the cytokine mediator. The new column we call the CA330, adding on the PVP material and can enhance the cytokine and endotoxin absorber. As you can see that this kind of the characteristic is quite important when we prescribe the treatment of a hemoperfusion technique. As you can see also that the major two mediator that we have and can moderate currently, including two things. The first one is cytokine and endotoxin removal. It's quite a long debate that which one that we should remove. When we look into the cytokine removal concept, the cytokine removal concept that we're talking about is the column is try to downstream our mediator, including the pro and anti-inflammatory response. But this kind of the thing is kind of the final concept, final pathway. But endotoxin removal, which triggering and try to binding the endotoxin or LPS, which is a part of gram-negative cell wall, they kind of try to tackle at the beginning of the sepsis cascade, like endotoxin. So the two main things try to control the inflammation at the beginning or at the spark or at the fire, like a cytokine. The case that we want to remove the cytokine, including because the cytokine is kind of the final common pathway, is a broad applicability in many process of inflammatory setting is not only in the sepsis but also in the non-sepsis pathway. But and also data from literature show that this kind of cytokine removal can significantly decrease the mediator such as the key one like IL-6, improve clinical like decrease vasopressor dose. On the other way, if we focus in endotoxin removal because we thinking the endotoxin is kind of the triggering pathway, and we have like the kind of the certain target cut point, not like a cytokine which still don't have any clear cut off. For example, the literature clearly show that endotoxin activity assay between 0.6 and 0.9, and we apply the treatment at this level can improve mortality. And also based on clinical evidence like a UFAS, Euphrates, and also the Tigris study show the benefit of outcome. So in terms of the one of the key main factor is the patient selection, because this is quite an important one, because as you can see that for the sepsis, this is very difficult to define the exact time that when the patient develop the sepsis. So for the time frame that we're talking about, the timing, if we only fix the time point, it's quite difficult in sepsis. So the thing that we mentioned and try to propose is to use the not only the timing but using the biology of the sepsis, including the mediator that we want to remove and using the threshold of that kind of the mediator that reach the toxic threshold. The parameter that we're talking about, including starting from the beginning like endotoxin down to the inflammatory cytokines such as TNF-alpha, IL-1 beta, IL-6, and also the anti-inflammatory cytokines such as IL-8 and IL-10, and also including the late response, including the HMGB1 or complement activation or myoglobin. And the way that we think about to remove this mediator is depend on each cartridge that has different capacity. Another thing that we need to account when we're talking about the timing is not only the mediator but also the threshold that triggering the treatment. For example, no any single validate cutoff point exists, or no any, we're still waiting for the base cutoff, the base marker and the base threshold. One of the promising one that has been published more is endotoxin activity assay between 0.6 and 0.9. Other example of the threshold including the IL-6, and we don't have any clear consensus for the IL-6, but it's quite been accepted that if the IL-6 level more than 1000 per picogram AML, this might be the threshold for us. Not only the mediator cut threshold, but in terms of our real practice, sometimes we use vasopressor escalation as the triggering point that we think about to start the cytokine removal. And in this one, in some study, they use cutoff point at 0.2 or 0.5 as a cutoff point. And also some study also use the increasing or persistent elevation of lactate as the marker of the hemoperfusion initiation. Allied with the, also in the Tigris study, they also used a kind of the MODS score more than 9 as an organ failure burden indicator to start the hemoperfusion technique. In terms of timing, we don't, as mentioned, that in sepsis it's difficult to identify the timing based on the fixed time point. But in the literature, based on the observational study, they tend to start the treatment before between 12 to 24 hours. So this kind of the mediator and threshold is kind of a major key concept for the timing that we choose start hemoperfusion. In terms of the literature, we can divide into 3 categories. The first one, based on the, at this time we focus in the HA330 and HA380. The sepsis RCT, by using this kind of the device, there are 2 major RCT. The first one by the same team is a small study from a randomized trial from 44 cases, and show that this treatment can mitigate inflammatory response, improvement of the SOFA score, but no any different in terms of the mortality and other clinical outcome. Subsequent study by the same group also shows the improvement of the surrogate marker and some of the clinical parameter, including the ICU mortality. And in these two studies also, they tend to start the treatment at the early phase of the sepsis. In the study based on not the randomized trial but prospective and retrospective way, one study start the treatment at the early phase with the mean time about 28 hours after sepsis shock and septic shock. And this is one of the largest study, up the number of the patient enrollment up to nearly 400. And they could show the survival benefit around the difference around 11%. Subsequent study that applied the treatment a bit late at the mean more than 62 hours. They could not, and they show that this is when applied this kind of treatment, no any survival benefit from the hemoperfusion technique. And sometimes when we apply the hemoperfusion technique, we also apply in the setting of the patient who have sepsis and AKI requiring renal support. In this case, this summarize all the key study. The first one from the small case series show improvement of some surrogate marker and clinical endpoints such as vasopressor dosing. Subsequent study in the prospective and the small RCT in this setting also show some improvement of surrogate outcome and clinical outcome. I also try to summarize all the timing of HA330 and focusing on when the time that they start. As you can see that based on the previous study, the study that showed the benefit of the treatment seemed to be start the treatment at the early phase. And one of the late highlight, this is a retrospective one, show the improvement is futile if you apply the treatment more than 62 hours. But again, this is not a randomized trial. But just try to give some idea about the outcome of the treatment depend on regarding on the timing of initiation. Currently, there are also at least 5 major studies the ongoing try to address the role of the hemoperfusion in sepsis. One of the trials also coming from Thailand. This is one of the largest RCT that just published in Critical Care Journal 5 days ago. We call the CLEAN trial or CLEAN study. This is a study by Professor Ratanarat and the group team. This is a multi-center study, and this is a graphical abstract of this study, multi-center study from 128 adults. The threshold that they start the hemoperfusion is the timing of the patient who have the septic shock and requiring the dose of norepinephrine more than 0.2 as a triggering factor. And they exclude the patient if the threshold has been met beyond 24 hours. So this treatment definitely is the one of the study that try to also not address the importance of early hemoperfusion initiation. They randomize 1-to-1 into HA or hemoperfusion treatment and the standard treatment. And the protocol study to randomize them to get the treatment within 12 hours. And the patient received 2 sessions of hemoperfusion, 3 hours for each session. And as you can see that for the primary outcome, the mortality, even this no any there is a trend of the improvement of the mortality, but not least statistical significance. But you can see that the is kind of the 14% difference of the mortality. And we also try to calculate that if we want to reach to the significant outcome, we may need to increase the such study sample size up to around 350 of the whole cohort. In this study, they also do the adjusted mortality rate hazard ratio for the interleukin-6 at the time of randomization and vasopressor inotropic score. At this time, and for the adjusted model, they show that there is a significant reduction of the mortality and the adjusted hazard ratio is 0.62. So, in the post hoc analysis of this study, they show that in the adjusted model for in the unadjusted, they could not show the benefit, but in the adjusted model, they can show the benefit of the survival. And this is data shown in the supplement table 3, show that when adjusted for interleukin 6 level at the beginning and the vasopressor in inotropic score, they can show that the treatment seems to be improved of the outcome. The median time of this study very interesting. They can randomize the patient in the very early, or the median time about 6 to 8 hours. The second thing that interests in this one, as you can see that the interleukin 6 level in this study is quite high. The median in the hemoperfusion group of interleukin 6 level up to 7,600. On the standard group about 3,000. And in this kind of the level, when we adjust to the same level, we could show the benefit of the hemoperfusion groups. So in my conclusion, I think it's not only the timing or the early apply, but the way to improve the clinical outcome in septic shock patient when we would like to apply the hemoperfusion technique. We should not only identify the early time point, but we should select the right target, the right mediator, including the right patient. So the thing that may answer this question is the right clinical phenotype. And based on the clinical finding from all the literature in the past, I think the group that show the phenotype of requiring the high dose of vasopressor, high interleukin 6 level might be the target for future trial of the hemoperfusion. And also the timing that is defined only a specific time point is might not be the answer, but the answer should be the parameter including the clinical phenotype to be the triggering for the RRT, for the hemoperfusion technique initiation. Thank you very much for your attention.
Thank you. Can you join here for a very quick discussion? I think we have 10 minutes. And while you prepare for questions, I have a question. You can have a seat. In very, very sharp way, what is your suggestion to identify which kind of patient and what time to apply? Very practical. And then I will ask you the same question.
As I mentioned in my presentation, I think the right patient is the patient will require or trained to require more high dose vasopressor, and the cutoff point may be around cardiovascular SOFA score 2. And also, I think it's not only vasopressor, but we need to combine with some clinical marker or clinical mediator that we want to remove, such as using EAA or using the interleukin 6 as another clinical marker to combine together to identify the right patients.
And when do you want to start?
As mentioned, we don't have specific time point, Professor Ronco, but we use clinical phenotype, and we have critical threshold as the guide of us to start the right timing.
Do you agree?
In our hospital, we are implementing a new protocol when we will start or consider hemoadsorption when we have noradrenaline dose higher than 0.3. If we add a second pressor, you consider it most, and an IL-6 higher than 1,000. That's what we are trying to do, ideally in the first 24 hours.
So, one specific recommendation. We don't have enough biomarkers that tell us where we are. So we have to rely on clinical evaluation of the patient. If a patient is clearly hypotensive, in shock, and has a capillary leak syndrome, we can expect this patient to have high endotoxin or cytokine circulating. So we can measure them, but we have to follow clinical indication. And my recommendation would be earlier is better than late. The problem with earlier is that somebody may say, oh, yes, but you are doing a futile treatment and so on. What do you think, Marlies?
Any treatment can be futile if given to the wrong patients. But in this case, Professor Duarte showed the inflammatory pathways and processes after the onset of sepsis, where you have this inflammatory peak, the release of inflammatory mediators. And if you want to remove them or cut, that's the time, that's the early phase where it's likely to be more effective, as nicely shown by the figure which you displayed, where we have the cytokines, which are all peaking at the beginning.
Thank you to the speaker. Thank you very much, Marlies.